start off everyone with a quick Pathways for Kids update, but let's see, Michaela, can you hit record for us?
Yes, we're recording now.
Okay, great. All right. Good to see everyone. Got over 45 now, so that's great. Um, we got a great speakers for today. My name's Jason Miller. I serve on the steering group for Pathways for Kids, and I've been involved since the beginning. And in my day job, I'm a director of safety and quality at Boston Children's, and I lead the enterprise clinical pathways operations across Boston Children's out of our Department of Quality and Safety. Um, we're expecting potentially up to 80 some folks to join, so we are going to be recording. We just want to let people know so that we can share the recording to those who aren't able to tune in, like we have been in the past for all of our quarterly webinars. And we're going to start off first with a presentation by Courtney Titus, who's our executive director and president of Pathways for Kids, and she's got some organizational updates to share, and then we'll be pivoting. I'll be pivoting to introduce our guest speakers for today. So take it away, Courtney.
All right, you hear me okay?
Yes.
Perfect. So yeah, thank you. I am Courtney Titus. I'm over at Johns Hopkins All Children's. I'm very excited to talk to everyone. I thought it would just be nice to kind of start this off with some updates. Last webinar, we had a few technical issues with an echo in the beginning, so you may have heard this once. I apologize if I'm repeating it, but I'm excited to share that we are officially a nonprofit. We have been since December of last year. And so this is your board. I'm sure you know all of our faces, but if you haven't, please say hello if you do or do not know us, and if you've seen us at the conference. This is an amazing group of people. This is why we are a nonprofit, and I really am grateful to work with such a great team. This is our structure. All of this is on the website, and so you've probably seen this 100 times, but this is our structure. And oh, can you mute, Jason? Got a little echo. We don't want to have the echo issue. Okay. So this is, we have a board of directors, which is the officers and myself, and then our steering committee. And our best practice collaborative, I just added a web page for that. So if you're interested in that information on what we're doing right now, that it's posted on the website. I used chat to just put some information together about our group, and it's not complete. I found out Nebraska is not in there. I don't know why I didn't catch that, but it's pretty good for ChatGPT, right? It is cool because you can see how many members we have. So we're up to 249. It's probably 250 now. I haven't updated it since yesterday. We do have, if you haven't seen, we have a professional membership that I'll talk about. So we have 61 professional members and 188 community members, 64 hospitals and health systems over 32 states. And I saw yesterday I knew we had Canada before, but now we also have New Zealand. So welcome, New Zealand. And so a little bit about that professional membership. We welcome everyone here to join if you're interested. We try to keep it really low cost. It just keeps the lights on. We're all volunteers, so it is just to help kind of pay for the cost of the nonprofit. The benefits are that you'll get access to a member directory, which I'm going to show you in a minute. I just added a feature like yesterday that you'll be able to kind of find people who want to mentor and what their details are. You'll get access to the forum. I'll show you that. These webinar invites, which are quarterly, all of the recordings of past events are locked under that membership. So if you want to see any of the previous webinars, you'll have to be a professional member, and also all of our conferences. So there's 12 conference lectures with all of the PowerPoints from that. That's really useful. There was a lot of really great lectures out of that. And then any shared pathway documents, also early registration and registration discounts for the conference, and then opportunities to join our committees. And so I'm going to just really quickly just show you what's on the website. There are a lot of great resources. These are all things I just mentioned. This is what the member directory looks like. I'm picking on Daniel and Emily. Sorry, guys. But it's actually really nice to kind of find people. Unfortunately, you can only It's listed alphabetically by first name. I'm working on fixing that. I am not a web developer, so bear with me, but you can use the search function. So if you want to search by state or hospital, that feature works very well. It's very sensitive. So definitely use that. Also, if you're a professional member, go in and add your photo and your details. There's a bio section, so you can kind of see the details of like what hospital, location. I just added this option to say if you are available to mentor, if you're looking for someone to mentor you, and there's a section where you can add details. And so this is my bio, if you will, or my member profile, and it has a lot more details in there as well, including areas of interest, any presentations for this last conference and then future conferences, any Pathways for Kids committees we are on, best practice collaborations that we're on, and my role with Pathways for Kids. So there's lots of good intel in there if you leverage that member directory. There's also our forum. It is real basic. I know it's not very sexy, but it does work well, and you can reach out to your colleagues and start asking questions and share detailed information. If you're a person that doesn't remember to check forums like me, I'm an ERPA, I have the attention span that's very small. Subscribe, the subscribe button, when you click it, it will email you when anybody responds on those. And so there are 5 forums, I think. You can subscribe to all of them, you can subscribe to one of them, you can subscribe to just one thread, and you should get emails for any updates. If that's not happening, let me know and I'll kind of work through that with you. I'm going to speak for Sophia here, but we do have conference updates. Our conference officially is February 8th through 10th. Next year, it is at our hospital again. We do have a submission for a grant, so I don't know what the details on the cost are going to be, but I can tell you that our call for abstracts is going to be open tomorrow. So if you're interested in presenting at the conference, presenting work that you've done, there's one submission for all the types. So CME presentation, workshops, or poster sessions, or rapid fire panels. So those details will be on the website as of hopefully tomorrow. That will close on August 17th. So please get your abstracts in. You do not have to have final data. You can be in progress work. And I think that's important. So if you have any questions, reach out to Sophia or myself, or anyone that's on the conference committee. And then I think that is it. Oh, this is just a fun fact of this past conference, we had Dr. Beachgen came and made a little appearance. So it's a fun time. And speaking of, I wanted to pivot back to why we're all here today. So Daniel, Kelly, and Katie won for the Judges' Choice Award for the poster session that we had during the conference. And if you are curious what that looks like, all the posters are available on the website as well. So that's all I got for you. I give it back to Jason.
Thanks, Courtney. All right. So without further ado, we're going to jump into our topic of the day. We've got Dr. Daniel Kelly and Katie Catalano from Boston Children's. As Courtney had mentioned, they were part of the team that won the poster presentation for Judge's Choice in February, and they're going to talk through their work on how to operationalize and sustain high-impact clinical pathways within a large pediatric system. Dan is a pediatric intensivist at Boston Children's and serves as the Associate Medical Director for Quality and Outcomes in the Department of Pediatrics. And Katie, maybe Jane could mute for a second. Yeah, thank you. And Katie is a Senior Program Manager in the Department of Pediatrics Quality Program, and she's been leading up their clinical pathways work within that department for the last 6 years. And, as they get through their talk, they're going to be highlighting approaches to pathway governance, multidisciplinary implementation, measurement strategy, long-term maintenance, all the things that a lot of us are challenged with every day in our own work at our local institutions around clinical pathways. So thank you guys so much for coming. And I think they will have a couple specific examples to share. So I think it'll be great. Thank you so much. And Dan, feel free to take it away and share.
Great. Thank you, Jason. Good afternoon, everyone. On behalf of Katie and myself, thank you for the opportunity to present and this kind of an expanded version of our poster that we were able to share at our last conference. Let's see. So just to start, we have no disclosures for this presentation this afternoon. And what we're hoping to do in our time together is threefold to really describe what we've developed as a structured approach to managing clinical pathways, really moving from project inception to pathway retirement. Speak about how we've developed a roadmap that tries to incorporate designing, implementing, and measuring pathways using standardized governance for this, using multidisciplinary engagement and implementation science principles. And then lastly, we'll finish with some examples of pathway case studies, looking to show how we can improve standardization, sustainability, and ultimately really focus on improving patient outcomes. For the agenda, we'll move through kind of what our programmatic structure is, where we fit in the larger grouping of pathway efforts within Boston Children's Hospital, discuss what we hope will be a scalable model for impact that you could consider for your institution, offer some impact examples, and then hopefully discuss together how we could apply these and move forward as a group. So to start, for programmatic structure, as Jason highlighted, he kind of serves within our patient safety and quality umbrella organization. And he, along with Michaela Nolan, Kristen Kelly, and Amanda Higgins, who are on this call, they really kind of serve to be a central resource to all the pathways within Boston Children's, where they really help to kind of serve for central coordination, a review of the pathways. They bring together our central advisory committee group and maintain the access points, be it our application or the website. And so really a lot of this is based upon their strong support for the program. But as far as groups developing pathways within Boston Children's, there's actually several groups that work kind of in parallel and ultimately kind of feed up through our safety and quality leadership group. And so we're seated within the Department of Pediatrics, and of the pathways within our department, we are responsible for 105 of those across 17 divisions. And what we do in our central group is support development, measurement, implementation, and ongoing review, all within consistent guidelines within the hospital, but kind of those focused specifically within our department. And I do want to note that many of our pathways, the early development of pathways really began in our emergency medicine division. So they still have the largest number of pathways as a division and really have a robust program that we're fortunate to collaborate with folks leading that division when it comes to pathways within the department. So what we recognize, though, is that people were pleased to see that folks were recognizing the value of pathways and that they became more accessible, especially with Jason's group kind of centrally organizing these for us and improving access to them. But what happened was that many were approaching with the idea of creating more pathways. And as folks recognized the value in these, they also started to suggest that we reprioritize, particularly how we review them, the course of reviewing, whether or not we measure. And so it really kind of became a barrier to how do we manage a pipeline of pathways such that we are able to be efficient in our work and make sure that all the materials are kept up to date and that we're incorporating new pathways, but also being mindful of the need for retirement of measurement and active engagement once something becomes incorporated into practice. So we'll speak a little bit about that. What we also realized is that unfortunately many development teams were quite interested in developing the algorithm itself, but in turn deferred or overlooked measurement at project inception. And then later on would go back and want to take a closer look or start to measure, and that became more difficult. And then what we also recognized is that without measurement, it really limited our ability to determine if our pathways were improving patient-centered outcomes, which is our primary focus for the program. And so what we're able to do is kind of, through these barriers, recognize that really we needed to reframe this as an opportunity to those in the department that were engaging in pathways work. And so what we recognized was that as we all share these goals, the pathways for us were really an opportunity to standardize evidence-based care, enable real-time clinical decision-making, and ultimately reduce variation and improve outcomes. How do we try to do this? And that's where we've come up with this scalable model for improvement and ideally impact. And so what we've done is kind of built out a system that consists of 5 components. And we'll go through these in detail. But the first is establishing governance and accountability structure. That then leads to a standardized process development. As we're developing these algorithms, we look to embed measurement strategy. We're proactive in developing an implementation infrastructure. And then once a pathway is launched and it's being used by clinicians, we really are attentive to the lifecycle management and sustainability of the program overall, looking forward to see that, as we move pathways through these phases, we could easily overwhelm the system if we're not careful in kind of peeling back some of the active engagement on these. So what I'm going to do is I'm going to pass it over to Katie Catalano, our director, and she's going to review our governance and operating model.
Great, thanks, Dan. And so this is just a quick overview of the governance and accountability structure within our Department of Pediatrics Clinical Pathways program. So here first on the left, just making sure that you have that established effective governance structure. So it's so important to define the different roles and have that accountability built within the structure just to be successful. And so this contains a central oversight structure, which is our team, in addition to making sure that we have designated clinical champions from the start. So it's so important that there are leaders that are identified prior to development to make sure that they're the go-to clinical folks for these pathways. We also have our data and QI support, which is really important. So just making sure that we have that integrated within the pathway process, in addition to multidisciplinary collaboration, is critical to making sure that everybody who touches these patients for care has a say and that we have their opinion when we're going through these pathways. So we always stress multidisciplinary collaboration, which is really important. And then second here, we have just having our standardized intake and prioritization for the pathways. So prior to accepting any clinical pathway or starting development, we have a structured application process. And so luckily we have Jason and his team who have the application process for the entire hospital, which we'll go over in a little bit. And so this essentially just makes sure that whichever clinical teams are looking to develop pathways, that there's a real clinical need and evidence base behind whichever the topic would be, that there's a defined scope and that they've really outlined who that targeted population would be, that they've started thinking a little bit about proposed measures, especially outcomes, is really important. Ensuring that there's a team that's already bought into the work. So just identifying who those stakeholders are. And then finally, that transparent review and decision framework that we'll talk about in a little bit. And then finally here on the right, we have our champions as drivers of success. So just having that clinical champion accountability. And so this looks like just establishing the expectations from the start is so important. So I think with they really lead content development and evidence synthesis. So before we start a pathway, we always ensure that there is some evidence backing that pathway, and that they're really the drivers of what clinical information goes into that pathway. They also help lead the measurement strategy design. It's really critical to make sure that the metrics that we're picking are clinically relevant to the actual pathway itself. They take a lead on implementing the clinical pathway and then also ongoing pathway maintenance. So we always try to emphasize that this is a really long process of once the pathway launches, that we make sure that that's not the end of a champion's role, and that there's always this ongoing maintenance part of it as well. So, and then kind of getting into that second piece of our model of standardizing the development processes. And so we always start with where do we begin? So generating the idea. And we fully support that most clinical pathways will be a part of an intervention for a specific QI project. And then just ensuring that it aligns with local strategic planning. So that divisional strategic plan that our divisions use to guide their QI portfolio. And so we have a really quick example here for C. diff testing for the infectious diseases team. As you can see here on the left, we have our driver diagram. and circled is a changed concept, which would be the clinical pathway development. And so they had identified this as a potential change concept within an existing QI project. And on the right here, when we went to rank the different change concepts using an impact effort matrix, as you can see, clinical pathway development ended up in the high impact, high effort quadrant of this. And so they had determined that this was something that they wanted to prioritize. And so once this idea comes about, we have the standard application. So the champion would submit the application on behalf of their team. And so this is the piece that the Central Pathways team manages here. And so there's that standard, just, I guess not meant for reading, but on the right, we have a red cap that Michaela will manage on our behalf. And so this application just includes information, background, and rationale, making sure that they share that evidence base with us, identifying potential barriers or challenges that they might expect to see with building this. We also ask for some candidate measures, so 3 to 5 metrics, and then having them list some existing stakeholders. And so this isn't all that's in the application, but this robust process really shows the commitment. If a champion is going to fill this out, we really want to make sure that they understand what's necessary to be able to develop the pathway. And so any Department of Pediatrics related applications get forwarded to us by the central team. And then once we receive those applications, our team goes through our standard review and approval process. And so we have a form here that just goes through some pretty straightforward questions of just, is the proposal appropriate for pathway development? Really going through and making sure that there's a problem to be addressed, et cetera. And so we have our DOP QI leadership members that will review this. So Dan, our director, Ann Stack, who's also on this call, along with our quality improvement consultants who are here, and myself. So we have at least 6 or 7 folks that will review the applications, and then we'll collate the information and then review it at a meeting together to make sure that we are all on the same page, don't have any questions, and then we usually can then make a recommendation for that group. And then just for next steps, usually it takes about 1 to 2 months to complete this process for us. And so the different determinations we tend to have. So if we feel like a pathway is appropriate, we'll approve it. So we'll share the feedback with the submitter and then connect with them on next steps and development timeline. Sometimes we will have some outstanding questions that we need more information for, so we'll reach out to them and request them, and then we'll probably get together another time just to make that final determination. And then finally, if we feel like it's not appropriate for a clinical pathway, we usually defer the application and then have a discussion with the whomever applied, just communicating that decision. And then we always try to offer recommendations for different strategies that might be more appropriate, like say a local protocol, for instance. And so we don't necessarily just say, sorry, we're not going to do this. We really try and be helpful and steer them in a different direction. And so I think once we have accepted a pathway, we wanted to share, this is our author checklist that we developed maybe 5, 6 years ago now. And so we always send this to the author or the champions. And so this serves as guidance for them, acknowledging that although this is their checklist, our team supports them throughout each phase. So as you can see on the left, we usually have the 5 different phases. So prepping the foundation, designing the algorithm, developing measurement, implementation planning, and then the approval. So this just keeps all of our steps on track. And we also have an expanded version of this that gives details that I won't get into today, but this is a great tool that champions really find helpful. And I think some of you might ask, well, how long does it take to develop a pathway? And so we have our sample development timeline acknowledging this is our ideal state, depending on the scope of the work and just different other factors. Sometimes we don't always do this within this time frame, but this is always our goal. And so as you can see here, we have our kickoff meeting where we do intros and really just make sure that we have the project background down, talking about what the scope is of the pathway here. And I think throughout these meetings, the champions are getting together their initial draft for us to put into clinical pathway format. I think next for meeting two, what I wanted to highlight here is we will start our algorithm drafting together. But what's really important is that stakeholder engagement and awareness early on. And so ensuring that the champions and project teams from each areas bring back the information in the drafts of the algorithm as they see fit to their local areas. And so although they can't have their entire division working on a pathway, it's really good to bring that pathway back and engage stakeholders early on so that they're aware that the pathway is being built and can give some feedback along the way rather than waiting until it's already completed. And then our third meeting, as we continue algorithm design, we'll start the conversations around, well, how do we want to implement this and which strategies might be most appropriate for this group, which Dan will get into in a little bit. And then in addition to that, I wanted to highlight that we also start talking about measurement planning pretty early because the ideal goal is to, when the pathway is posted, to start doing measurement for that pathway. So we always try and embed all of these steps within the earlier stages of development. So everything's happening in parallel to each other. And then finally, for meeting four, we ideally would have a final draft, and then also would review supplementary materials like the appendix or any other forms that support the pathway. And then finally, in meeting five, we use as more of a check-in to see how the approval process is going or will go. And then we continue talking about measurement, hopefully finalizing the measurement plans soon, in addition to finalizing our implementation plan. And then here on the right, you'll see two other steps here. So all of our pathways go through the standard leadership approval that's set at the hospital level. So if there's any antimicrobials included, we always include their team right from the beginning. It also requires that final champion sign-off, nursing leadership, pharmacy, and chief sign-off. And then finally, here on the right, we'll have the Clinical Pathways Advisory Committee, so the CPAC group approve the pathway. So that usually with new pathways includes having specific CPAC members be assigned to the pathway. We'll incorporate the feedback, and then at the quarterly meetings is usually when there's the final stamp of approval. So I think one thing throughout all of this is we're always getting feedback from different leaders or stakeholders that we try to incorporate when we get them, rather than waiting to incorporate everybody's feedback at the end. So this is, again, our sample timeline, and this is always our goal.
Thanks, Katie. With all things QI, it always doesn't go as planned. So I can certainly attest that this always doesn't look that easy, but it's what we aspire to. There are certainly times where this does move along pretty quickly. It really depends on how much alignment the different clinical teams have amongst themselves as they start drafting, but this is what we aim for. And as you could probably put in multiple sub-meetings in here amongst the content experts as we move through. One thing I did want to highlight that Katie mentioned was that we really do try to emphasize incorporating pathways into larger QI efforts. We really find that those are the pathways that tend to be the most successful, both with engagement, especially with implementation. It's when they're an ongoing effort rather than just having the effort be developing of the pathway and getting that into the library. It's when it's part of a larger effort that we really see the most impact. And to that end, that's where we really try to embed measurement from the start. And so we kind of 6 phases of measurement that we'll walk through. And so to start, we really emphasize at the point of application, developing candidate metrics. And what we try to do is have measurement that allows us to evaluate the impact of the pathway without overwhelming the clinical team as well as the data analyst. And so what we aim to have are perhaps 1 to 2 clinically meaningful outcome measures, 1 to 2 process measures, and a balancing measure. And then as applicable, using equity stratification and being explicit about how we're stratifying within each of these measures. We do recognize that many of our clinical leads come in with a research background and often approach us with pretty lengthy measurement plans, and that's just not something that's sustainable. And so we really have to work with them through several conversations to help them see that we want to make sure that we're using high-level metrics that are clinically relevant, and also as much as possible avoiding chart review. There's a lot of tendencies to offer to do chart review, and I'll double check this, but we often find that everyone's busy and other priorities arise, and it's really hard to get back to providing measurement back to the team if we fall in the trap of chart review. Once we settle on those measurement initial goals, what we try to do is in the development process, actually build it into the checklist and templates so that as we're moving through the development process, it's an action item that we're highlighting in the meeting series that Katie identified. And then once we do define those measures, we will write out formal measurement plans, and then we pass them off to our analytics team. And what they will do is to help redefine the definition. They'll do an initial data pull and data verification. Once that is verified, we will put our baseline data into SPC as appropriate, engage equity analysis, and then bring it forward to Pathways leadership within our department to review to make sure that this is actually what we're measuring, that it's a clinically relevant measure, and that all the components are correct. So that way, as we move forward toward a launch, we are updating this data in a regular manner. And so to that end, we have a cadence review. When we initially go live with the pathway, we ideally would have measures reviewed every 2 to 4 weeks. This can be challenged if it's a lower patient volume, and so oftentimes that has to extend a little bit. But if it's bronchiolitis season, or it's some of the other more frequent presentations, we do have enough sample size that we can start to look at these things on a regular basis. And then we also put these into structured dashboards with status indicators that are accessible. And Katie has some screenshots of those that we'll see in a few moments. And again, these are kind of centralized so that they're accessible to others in the department so they can see how different pathways are performing. And then another thing that we've learned over time is making sure that we have version controlled definitions. As things evolve and we make small tweaks to the measures or we start to exclude, it's important that we keep those details, especially as many of our pathway leaders would like to ultimately move toward publication and utilize this data for publication. And given the number of pathways that we engage, we also recognize that if we had 5 metrics at a minimum, with over 100 pathways, our data team would quickly get overwhelmed with this. And so what we try to do is be really thoughtful about what we're measuring and for how long. And so as a pathway moves through development, ultimately implementation, where we actively study this, then we look at making sure that it's integrating into clinical practice. And at that phase, we start to space out our measures such that we might check them quarterly, every 6 months, and maybe potentially just annually. And then once things are truly sustained and we've reached consensus on that, we will ultimately retire the measure. We preserve the data pull and the measurement plan, recognizing that as folks move toward publication, or if there's a major update to a pathway, we might go back into active measurement. And so we're able to take that off the shelf, resume active measurement, and kind of bring those measures forward without starting from scratch again. But really what we're trying to do in this structure is to prevent kind of measurement sprawl, meaning multiple measures for multiple pathways, and preserve bandwidth amongst our analytics team.
And kind of building off of that model, we have our just internal clinical pathways review schedule. And so once pathway metric or a pathway is launched, we add it to our DOP internal review schedule. And so here we have this schedule where we try and do this. So for pathways in development are recently launched, we usually review those together as a team on a monthly basis. For every 3 months, once a pathway has been launched for a bit, um, measures that are in development.
Over here between the goals.
Sorry, or related active improvement is going on, we'll tend to look at it together for every 3 months, and then every 6 months, once things are moving pretty well and measures are established, and that the active improvement continues to move forward. And so again, this is our DOP team that will review these at our internal meetings, and then what comes out of those are these PDFs here that we created to share with the champions on our feedback. So we'll go over all of the different outcome process and balancing measures if they're applicable, share a little bit more about our interpretation of the measurement progress and how that links to any active improvement for their implementation planning or PDSA status. And then we provide a summary of just our overall assessment and next steps that we'll share. Usually we share these in meetings with the champions so that it's more of a conversation versus us sending this over email and hoping that they read them. And so we've really tried to turn these into more guidance documents when we have conversations with them at their established meetings after our discussion. And then as Dan had said, once that we deem the pathway is embedded into practice in collaboration with the champions, we always recommend retiring measurement. And here is an example of how we share some of this work with our institution. And so at our institution level, we have our safety and quality dashboards that every division and department have. They're called the squids. And so we developed one for our Department of Pediatrics Clinical Pathways program. And so here we just pull all of our work together. And so on the left is more around the different projects that are tied to clinical pathways. And so we have our project pages linked there if people are interested in learning more. We also have our annual report we do pretty regular or annually that will link so people have access to it. In addition to providing some resources, like the author checklist is linked just for easy access. And then here on the right is really where the measurement piece comes in. So we have our dashboard here at the top that pulls in all of our pathways metrics. And so it just helps so that we have all of our measures in one place, and that different areas around the hospital, if they're interested in the different work, can easily pull this up. In addition to having access to the different measurement review forms that we've recently started linking. And then finally, we have our SPC charts here at the bottom that are linked to our divisional dashboards. And so we try to keep these updated pretty regularly. So all of our measurement and data information are all in one place. And again, we really want to stress we try and be as transparent as possible so that everyone can be aware of what other departments, divisions are doing, and so on.
Thanks, Katie. Once the pathway is being drafted, we also really try to engage planning for implementation from the start. And Jason's team has nicely developed this tool as a central team, really kind of prompting awareness, agreement, adoption, and adherence efforts and how to engage this process. What we've done is built off of this reference tool and try to put it into a timeline so that folks can see as they're developing a pathway that implementation planning moves along with the development and ultimate launch and maintenance of a pathway. So you can kind of see over the initial 4 months, we're very proactive about how to think about engaging initially awareness and agreement, creating those strategies with the development team, beginning to implement awareness and then planning for adoption. In turn, once we are adopting, making sure we're planning for adherence and working through adherence strategies, and then launching at the time of it. Once we launch, making sure the adoption and adherence strategies are live. And then in the subsequent kind of latter 6 months of the initial year, thinking about, is the pathway embedded into practice? And if so, then starting to think about what would be the timeline for retiring, making sure that we've been measuring long enough to detect the difference we're looking for and that it is sustained. But more importantly, if the pathway is not getting embedded into practice, why is that? And are there other implementation factors or approaches that we need to engage to do so? And so what we think about is kind of, within the domains of implementation for acceptability, really driving stakeholder engagement and pathway review, making sure that it's culturized amongst the faculty and the advanced practice providers as well as house staff. For adoption, making sure that we've got provider uptake and that we're using Epic order sets and other tools that make it easier for folks to engage implementation of the pathway. For appropriateness, making sure that we've had enough evidence review and we're incorporating that and that the champions are actively engaged in the development of the pathway. For feasibility, we do workflow design, interdisciplinary review. And we've also recently had our human factors team start to look at our pathways. We just piloted this with asthma, but it was actually a very helpful exercise to see kind of some of the human factor lenses that we can think about for improving feasibility and engagement with pathways. For fidelity, that's where a lot of the efforts that Katie organizes come to play with adherence monitoring and dashboards. Penetration, we look at utilization, be it order set use or what we call click rates, meaning are people opening up the pathway on the website that Jason and Michaela and the rest of the team maintain for us. And then sustainability, looking at our biannual review process, the measurement feedback forms that we provide, and ultimately moving toward retirement. How does this all kind of come together in the end? And that's the life cycle management and ensuring sustainability. So at a minimum, all pathways will move through a biannual review. So every 24 months, these are brought back and the clinical champions are tasked with reviewing any updated evidence, any changes to the pathway, and moving those through a very similar approval cycle as the initial process. That said, there is room for off-cycle changes as evidence evolves or practice changes or there's structural differences that drive change. We are able to work with Jason's team to make those edits and get them posted so that way people are accessing updated information in real time. And then ultimately, once we have local implementation, ideally we'd like to share it with others so that they can ideally learn and benefit and perhaps implement within their local environments. And so much of the kind of measurement framework then facilitates publication because we've been measuring all along. And so once folks have kind of reached the point where the project has come to fruition, Pathway is part of the project, and there's evidence to demonstrate improvement, working with those teams to help them facilitate publication wherever it might be. What I was hoping to do is, in the time remaining, go through a couple of examples just to see how does this play out in real life. It looks very smooth and simple when we have it on timelines, but as you would expect, it doesn't always play out as much as we try to. So one example is our hyperammonemia pathway that I've led with Amy Kritzer, one of our metabolism experts. And what we recognize is that for patients with urea cycle disorders who are presenting with high ammonia levels, albeit relatively rare, we do have a number of patients in our system that present fairly frequently with elevated ammonia, and we need to be as proactive and as efficient as possible in treating this, recognizing that it's neurotoxic and can have catastrophic outcomes. And so our initial aim sort of decreased time from critical lab, so a lab serum ammonia above 100, to administration of an IV scavenger called Aminol, decreasing that time to administration, and then also ultimately for the patient, making sure that we were proactive in decreasing the time to an acceptable ammonia level less than 100, and then making sure that these were stratified by equity domains. And so as Katie mentioned, this was part of a larger improvement effort. You can see there the driver diagram and the impact effort matrix, and the pathway was developed as a tool within the larger improvement effort. And this is just a snapshot of the multi-page pathway, but what it really aimed to do is, based upon the ammonia levels, help teams expedite initiation of scavengers, including Aminol, and or initiation of hemodialysis as indicated. In other parts of the pathway highlight kind of maintenance monitoring, frequency of lab sampling, when and how to reintroduce enteral feeding, recognizing the importance of avoiding catabolism in these patients. And so the pathway launched back in the fall of 2023. And as you can see on this individual measures chart, our mean time for time to critical med to Aminol administration was initially around 3.5 hours. in our baseline data. And then in time, we've been able to drive that down to about a little over 2 hours and 15 minutes. And we're still on our target of 2. We're still actively iterating on this and working to improve this, but we certainly have been able to make improvements here. And I think one thing that was effective in measuring this is that it really helped the bedside teams adopt this. These patients are cared for in multiple venues, be it the ED, in our ICUs or intermediate care unit. And so there's many stakeholders that had to be engaged in this process. And in addition to that, really partnering with pharmacy to prioritize med process and delivery. And that, I think, is one of the things that we were able to identify through these measures. It's not identified here, but looking kind of at the timestamps as the med is moved through our system from ordering to the bedside, we really identified that it was some pharmacy delays that were driving this. So that's one of the areas of focus on this project right now and trying to move it forward. And then this is looking at the ammonia levels themselves as a patient-focused outcome. And we've been able to drive down the mean net change in ammonia levels, meaning that we're recognizing this earlier and that we're being more proactive in treating these patients. As far as lessons learned, this data measurement actually being much more tricky than we initially anticipated. What we came to realize is that there's multiple ammonia values over the course of the illness, and if anything, the ammonia levels tend to continue to rise after the initial ammonia level, recognizing that the process is continuing, but we're not actively treating it until we've initiated therapy. So while we move through that 3 to 2 hour window of lab sampling, med processing, and ultimately deliver it to the patient, it's often that the values continue to rise. And so we had to work pretty proactively with the data team to try to clean this up and make it an automated measure. And we've learned quite a few things in this process. We also, given the number of stakeholders and areas in which this pathway was implemented, we recognize the importance of regularly scheduled meetings to maintain momentum, the need for multidisciplinary engagement, especially engaging our nephrology colleagues on consideration for dialysis and how to streamline dialysis initiation, and the need for continuous education, recognizing that although this is a relatively rare diagnosis, it's critical, but given the number of staff and the number of areas of the hospital for which these patients may present, that making people aware of the pathway and the urgency behind it has become initial and an important part of our sustainment effort. Another example is looking at standardizing duration of empiric therapy with antimicrobials for patients presenting with fever and neutropenia amongst our oncology population. And this was led by Doctors Illowhite and Degar. And so previously, all oncology patients who presented with FNN were continued on antibiotic recovery until their neutropenia resolved, as measured through recovery of their absolute neutrophil count. However, there was plenty of evidence to support that you could stop antibiotics before the count recovery in a safe manner. And so we were potentially having unnecessarily long exposure to antibiotics that in turn had risk to the patient in terms of side effects without benefit, and in turn potentially selecting up for antibiotic resistance. And so this group was aiming to standardize duration of empiric therapy and was looking to decrease antibiotic duration initially by 1 day. As part of a collaboration with our infectious disease team, this is back in September of 21, they introduced this concept of a defined duration, and that took a lot of alignment between oncology and infectious disease through a series of educational conferences, online modules, and then ultimately providing feedback to individual prescribers in standardizing duration within the order sets. And you can see also there a screenshot of the pathway that kind of describes exactly what we're looking for as far as count recovery and selection of additional antibiotics. And what this group has been able to do is to decrease the average days of empiric antibiotic therapy, starting from a mean of about 6.8 down to 5.1 without any significant increased risk to the patient. And so what worked well for this one is that once they identified the problem, it actually folks quickly aligned behind this. It was really getting folks to understand that this was a problem, not that there wasn't resistance to change. It was rather lack of recognition that this was a practice problem. ID was very helpful in this effort. And we didn't write this, the oncologist that led this program did, but they noted that oncologists love a protocol. So we would agree with that, but we're not calling out any of our colleagues. This comes from our oncology group. And finally, looking at C. diff, Katie had some screenshots of this earlier, but this was really a large effort as it really pertains to many areas of the hospital, and there's lots of practice variation about who orders C. diff and why. Dr. Vaughn Malloy and Waddell from our infectious disease and antimicrobial stewardship team led this effort. And so what they recognized in their drivers was that it's a common healthcare associated infection, that there's complex diagnostics and management, especially when we try to discern colonization versus infection. There's variable therapeutics out there, and there really was lack of pediatric specific recommendations at the time they engaged this. And so this is a good real life example of the kind of, although we initially said maybe 6 to 8 months to go live, their pathway took a little over a year to go live. And so they submitted an application in December of 2020 in several meetings. Ultimately, the draft pathway was submitted in the fall of 21. There was revision and feedback in November, and then ultimately went live January of 2022. And so their implementation strategies were several-fold. They initially started with standardizing rejection criteria for labs if there were repeat samples within certain time intervals. The pathway itself was developed and went live. They developed best practice advisory alerts at the time of order entry if there was reasons that Epic was detecting that we should not be ordering these. There was educational sessions. They were very proactive in data sharing back to units with a number of alerts that were firing and letting folks see kind of how their practice was evolving over time. And then in an effort to avoid alert fatigue as the project was implemented, they ultimately were able to revise that EMR alert. Of their outcomes, we've highlighted one here, and this is looking at the percent of tests that were ordered that were not indicated. And so they started with a baseline of about 20% of the tests that were sent in any given month were not indicated, and that's down now just about at their target of 15%. So in decrease utilization of resources and a decreased risk of kind of false positive tests that often result in overtreatment. And so what we'd like to do is recognize that certainly this is not just Katie and I. This is a large multi-group effort. And so there's our team, many of whom are on this call, and we appreciate their day-to-day efforts. There's the team led by Jason Miller and the Patient Safety and Quality Program. As I highlighted before, our emergency medicine colleagues really led the forefront of pathway development in our department and still really kind of take a lead on innovation and measurement. And then the many pathways champions and stakeholders that kind of drive this process with us. And then the individual physicians that were gracious enough to allow us to highlight their work today. I thank you for your time. And I guess, Jason, maybe we'll open up to some questions and discussion.
Yeah, thank you, Dan and Katie. One question as we're going through here that we had early on that's in the chat is asking about any barriers with pathway creators being excited about development and less engaged on the measurement phase, and how do you overcome those barriers?
That is a perfect question. That is why we've kind of baked it into the application process. We recognize the natural tendency to want to get the algorithm on paper, get it live, and say we did it. But really driving them to think carefully about how does this integrate into a larger improvement effort is one of the main factors in our review of the application. If we get the sense that there really isn't the long-term engagement, that does not help move the application forward. And then the measures, it really is an active conversation. Once given the opportunity to have some data analytics support, many of the teams are very proactive in trying to gauge that. But if anything, are looking to over-engage and drive too many measures. And so they see it as a chance to get some data support, which is great, but we're not looking to have 20 measures for every pathway. And so kind of making sure that we set the expectations from the beginning in that as we move through that author checklist, the very first pathway launch meeting is with the pathway leads to establish the expectation that this is the timeline. We are going to measure this. This is the manner in which we're going to measure. This is the draft measurement plan form that we need you to fill out and send back to us, and we'll review it together. And I think, as we've been more consistent in setting those expectations from the start, we've had better success in time.
Another question thread that's kind of in the chat here, Dan, is around support of the data analytics team. Like, how's that funded? and what has been the evolution of institutional support for such a robust pathway team. So a bunch about how Boston Children's has been able to kind of pull together such a big support around clinical pathways.
No, it's a great question. As we tried to highlight, there's different groups that are leading pathway development. We are fortunate in our department that the leadership has been very supportive of the Pathways program within the Department of Pediatrics, and the funding for our local team and our data analyst comes directly from the Department of Pediatrics, with some alignment and additional support from PPSQ, and so or Jason's team. But it's really driven by the fact that the department recognizes the value of pathways and also the value of measurement and in turn the academic value for the faculty. And I think that's really how we've been able to sustain this in the long term.
That's what I'm pulling out of the chat. But we do have like over 80 people on. We might have a minute for another question. Does anyone want to throw out a good question there for Dan? Please come off mute. Any others? Any questions? Well, it looks like we don't have any takers. Any comments? Not just questions, comments, or other things that people would like to jump in on. All right.
Ask if it's possible to reach out to your team independently and sort of ask for some of the follow-ups on some of the things that you're doing, if that would be okay.
Certainly, yeah, we welcome that. Please feel free.
Thank you so much. Amazing work and amazing presentation.
Thank you. And I hope it came through. I do want to highlight that Jason's team really they're the nuts and bolts of getting this out to the end user. They are the ones who maintain the Pathways website. They're the ones who kind of create much of the structure within the hospital. And they kind of are the first point of contact within the hospital. And they're ultimately, Michaela's constantly forwarding emails and things that she receives our way. So we really do rely heavily on them and appreciate their partnership.
Thanks, Dan.
Daniel, would you be willing to share any of those tools with the Pathways for Kids group? Is that something, maybe not all of them, but some of those forms, even some of the questionnaires, some of the bits and pieces looked really helpful, as we develop our own process. I'm thinking so very selfishly, but I think others may benefit from it as well.
Yeah, happy to discuss. Yeah.
I think we'll wrap up, guys. So it's like 2 to 3. Hopefully you're all set and ready to roll for your next meeting you've got to tune into. And I hope everyone's having a great summer. And we will get the recording out there and posted with the help of Courtney and others. So thank you so much for joining. And please reach out to me, Jason Miller at childrens.harvard.edu if you have any ideas for future webinars. We're always looking for great ones. So thank you.